Datscan ioflupane 123 injection is a radiopharmaceutical indicated for striatal dopamine transporter visualization using SPECT brain imaging to assist in the evaluation of adult patients with suspected Parkinsonian syndromes, PS. In these patients, Datscan may be used to help differentiate essential tremor from tremor due to PS, idiopathic Parkinson's disease, PD, multiple system atrophy, MSA, and progressive supranuclear palsy, PSP. Datscan is an adjunct to other diagnostic evaluations. Datscan was not designed to distinguish amongst PD, MSA, and PSP. The effectiveness of Datscan as a screening or confirmatory test and for monitoring disease progression or response to therapy has not been established. Contraindications. Datscan is contraindicated in patients with known hypersensitivity to the active substance, any of the excipients or iodine. Warnings and precautions. Hypersensitivity reactions, generally consisting of skin erythema, pruritus, have been reported following Datscan administration. Thyroid accumulation. The Datscan injection may cause up to 6% of free iodide I-123. To decrease thyroid accumulation of I-123, block the thyroid gland at least 1 hour before administration of Datscan. Failure to do so may increase the long-term risk for thyroid neoplasia. Adverse reactions. In clinical trials, headache, nausea, vertigo, dry mouth, or dizziness of mild to moderate severity were reported. In post-marketing experience, hypersensitivity reactions and injection site pain have been reported. Drug interactions. Drugs that bind to dopamine transporter with high affinity may interfere with the Datscan image. The impact of dopamine agonists and antagonists on Datscan imaging result has not been established. Use in specific populations. Pregnancy. Radioactive iodine products across the placenta can permanently impair fetal thyroid function. Administration of a thyroid blocking agent is recommended before the use of Datscan in pregnant women. All radiopharmaceuticals have potential to cause fetal harm. There is no available data on Datscan use in pregnant women to evaluate for a drug-associated risk of major birth defects, miscarriage, or adverse maternal or fetal outcomes. Advise pregnant women of the potential risk of fetal exposure to radiation with the administration of Datscan. Lactation, iodine 123, the radionuclide in Datscan is present in human milk. There is no information on the effects on breastfed infants or on milk. Advise a lactating woman to interrupt breastfeeding and pump and discard breast milk for at least 6 days after Datscan administration to minimize radiation exposure to a breastfeeding infant. Pediatric use. The safety and efficacy of Datscan has not been established in pediatric patients. Geriatric use. There was no difference in responses between elderly patients and younger patients that would require dose adjustment. Renal and hepatic impairment. The effect of renal or hepatic impairment on Datscan imaging has not been established. The kidney excretes Datscan. Patients with severe renal impairment may have increased radiation exposure and altered Datscan images. Overdose. It is unknown whether or not ioflupane is dialysable. The major risks of overdose relate to increased radiation exposure and long-term risk for neoplasia. In case of radioactivity overdose, frequent urination and defecation should be encouraged to minimize radiation exposure to the patient. Procedure. Radiation safety. Datscan emits radiation and must be handled with safety measures to minimize radiation exposure to clinical personnel and patients. Prior to Datscan administration, please read the full prescribing information for additional important safety information. To report suspected adverse reactions, contact GE Healthcare at 800-654-0118, option 2, then option 1, or the FDA at 800-FDA-1088 or www.fda.gov/medwatch.
Let's go on to our next case. I've called this the case of the disappearing tremor. It's another one of these complicated multi-disease cases that we see. A younger patient, 53-year-old, and he has a past medical history that's pretty significant. He has HIV, but he's doing well on triple retroviral therapy for 10 years. But of course, all of these treatments can have a number of different neurological side effects, so we have to be attuned to that. He also has hypertension, so he'd be at risk for stroke. He has pain, which makes it difficult to sort through. But among all of this, we did find that there was a complaint of difficulty with initiation of movement and some masked faces or change in his expression. After really digging in, he had a tremor that was present briefly in the left upper extremity. It kind of came and it went, but at this point that our residents and I were seeing him, really the tremor was not a major issue. And in fact, he was complaining of some episodes of stroke-like symptoms. So, the workup for this and the differential diagnosis was really quite large. But amongst all of this, I sort of focused in on these few Parkinsonian symptoms that he has, and I did decide to get a DaT-SCAN imaging in this case.
Okay. So really complex case, which I know the neurology clinic can be full of. And so this is the DaT imaging from the patient. Let's focus on the main rows here. So this is a little bit of a harder scan, and most DaT imaging is very straightforward, but there certainly are some challenging cases that you'll encounter in practice. So notice the background in this case is elevated. All right, when you look everywhere, the only areas of dopamine transporters are here in the striatum. Back here, even in the, for example, in the occipital region, you actually have purple. So this is elevated background activity is right away a hint that this scan is going to be abnormal. Okay, and so when that background is elevated, you want to compare the putamen to that background. All right, and as you can see, comparing this purple background is very similar to this purple in the putamen. So that putamen is far less than 50% or greater activity. Okay, so this meets abnormal criteria. The left side is actually relatively preserved. Okay, with the elevated background activity, it truly actually probably is also slightly abnormal. But we have this asymmetry. You only need one side to be abnormal to call the entire scan abnormal. For those of you who may have seen DaT imaging before, you might notice some difference here that the comma heads here almost seem fused in the middle. That's an artifact that can be seen from a couple of things. Head motion is one potential cause for it. Even or these are small structures, so even a little bit of head rotation can sometimes blur that space in between. And also, particularly in patients who might have some mild claustrophobia and we can't put the scanner heads really close to them and you have to have them a little bit farther apart, it can also cause that artifact as well. So abnormal scan with particularly abnormal decreased uptake in the right putamen that is not significantly higher than the background activity.
Right. Well, so what our final diagnosis with is after getting this scan, we know that this is abnormal. It puts it into the Parkinsonian family of disorders as sort of the main thing that was going on in this patient. So it's a case of Parkinsonian features, but without significant tremor when we saw him. And up to 30% of patients with Parkinson's disease don't have tremor. And those sometimes get missed or delayed. Initially, we thought he had this postural instability gait disorder subtype of Parkinson's, which we see without tremor but bradykinesia and rigidity, and that's for those that like to split things into categories. That's one designation. Based on this, we did try him on levodopa. And he did get some transient response, and eventually we even used very high doses, but ultimately that stopped working. Our final diagnosis in this case is atypical Parkinsonism, which does have Parkinson's features, but we know that they don't respond to levodopa, probably because there's more extensive damage in the striatum. The receptors that receive the levodopa, the dopamine receptors and downstream seem to be damaged. The latest nomenclature for this disorder is actually called multisystems atrophy, is the proper diagnosis now of the Parkinsonian subtype. So ultimately that is his diagnosis, and we do have symptomatic treatment, but does not include levodopa or dopaminergic medications.
Great, thanks, Scott. And it's important to note at this point, because I get asked this a lot, for any given individual, the DaT imaging cannot reliably distinguish between idiopathic Parkinson's disease and multi-system atrophy or progressive supranuclear palsy or all the other atypical Parkinsonism. If you actually look in the literature, if you do a large population-based look at their DaT imaging, there is a more common unusual pattern, which actually this patient just happens to kind of fall into. But on an individual basis, you cannot use it to distinguish between, for example, this case, PD versus MSA. But this more balanced loss where you still had relative preservation of sort of that comma appearance, but that background was elevated, is seen a little bit more with the atypical Parkinsonisms, where they may break the rule a little bit more often of that posterior, losing the dopamine transporters from posterior to anterior, very classic in idiopathic PD. The atypical Parkinson's syndromes will break that rule a little bit more, but not useful on the individual level.
Yeah, well, that's the fine details are interesting, and one thing that's great is that we get to discuss these cases in detail together, and sometimes there's some information that is a sidelight, but in the future maybe we'll understand these disorders and the classification more.
Yeah, and it's still important also, I'm a believer in that when you're looking at that imaging, you should be really blinded to the history, so it doesn't bias you in that way.